Not. Where's that lady who was here? Martha? Yeah. Charming. She's pulling people in. We're ready. Okay. Hello, everyone. We're ready to get started. Everybody kind of file in. Let's wait another minute or so, and then we'll get started. Everybody's almost here. Okay, let's go ahead and get started. First of all, welcome to this session, which is on active clinical trials, both in pancreatitis and pancreatic cancer. My name is Steve Pandal. I'm from Cedars-Sinai Medical Center in Los Angeles. And with me is Dr. Min Lee, who I'll tell you is from the University of Oklahoma Cancer Center. And so the way we're going to operate is that I'll introduce the first three speakers who are talking about pancreatitis-related trials, and Min will moderate the second half, which is on pancreatic cancer-related trials. So our first talk is by Mustafa Arain. We saw him earlier. He's coming up. So Mustafa is from Adventist Health here in Orlando. He is a interventional gastroenterologist in pancreatic biliary disease. And he's going to give us a talk about the landscape of endoscopic and endoscopic therapeutics. Good to have you.
Thank you, Dr. Pandal. I'd like to thank the APA and the organizing committee for giving me this opportunity to present. I'm humbled to be presenting in this meeting with some true experts in the field, and both overall as well as in the field of endoscopy. So to get started, thank you. I have no relevant disclosures for this talk. I'll break it down into recurrent acute pancreatitis, chronic pancreatitis, necrotizing pancreatitis, which kind of is a field in its own. We were just hearing about that earlier today too, in pancreatic cysts. I won't be going over the role of endoscopy in pancreatic cancer. There is a separate talk on screening later today. And with acute pancreatitis, I think the key trial to start off with, of course, is Greg Cote's led study through the NIH, which I know Greg is here in the audience and has done a phenomenal job of designing and coming up with this trial to explore the role of endoscopic therapy, specifically minor papillotomy in the setting of recurrent acute pancreatitis in pancreas divisium. This is a sham-controlled, single-blinded, with a blinded outcome assessment, essentially looking to see if there is an improvement in patients' episodes of pancreatitis as well as other outcomes. The sham arm is EUS only, so patients get a procedure, but they don't know if they're getting an ERCP or not, and then the interventional arm is ERCP. This is a multi-center study that has been ongoing for almost 4+ years and is sponsored by the NIDDK. The primary outcome, as has been set by the investigators, has been to assess the reduction in acute pancreatitis episodes. And to qualify for this, patients have to have two or more discrete episodes of acute pancreatitis. And then there are secondary outcomes, including the frequency rate of the episodes, as well as patient-centered outcomes, which, as was discussed earlier, is an important way we should be assessing patients, as well as the development of chronic pancreatitis and creating a biological and data repository. Now, when I was in San Francisco prior to coming here, I was part of the study, and I had the pleasure of sort of working with Greg, but also I remember him being on these calls and the frustration that he had to contain with all of us for the lack of recruitment. And all I can say is thank you for your patience. But some of the issues that sort of came up, and these are issues related to acute pancreatitis studies, include the difficulty overall to conduct such studies, asking an appropriate question and asking it in a way that can be answered. I think that is the key thing. And I think if we take this study as an example, the reduction in number of episodes is one marker, but they're also trying to address various other aspects of pancreatitis. But we have to start somewhere. The irony with a lot of the trials with pancreatitis and endotherapy is that our actual intervention may have caused the problem that we're trying to treat. So this is a real dilemma that we have to kind of deal with. And outcome measurements, as I stated, have to be, at this point, can't be focusing on single events, but multiple factors. There's a heterogeneity in terms of how patients present. You know, what is the definition of an acute episode? How many days? What is true resolution? Is it symptoms only? Is it imaging modalities? Is a mildly elevated lipase a marker of inflammation or not? All these factors that we don't really have a good handle on, but we still need to forge ahead. And then a big issue in this kind of study is intervention versus no intervention. You know, the expectations a patient gets referred to a tertiary referral center to have an ERCP, they're coming with the mindset that my pancreatitis may be helped with an interventional procedure. And now you're talking them out of potentially having the procedure or having a sham procedure, which can be very difficult. Recruitment challenges beyond this, and then infrastructural needs and cost, as was discussed earlier. That said, I think this study is approaching its halfway stage for an interim analysis, and hopefully there will be enough good data for the study to be completed as planned. Moving on, I think a lot of the interventional stuff that comes out in terms of pancreatitis is in the setting of post-ERCP pancreatitis prevention. As we know, it's a frequent enough problem and has been a subject of great interest and study. As time has gone on, there are multiple modalities that have been shown to reduce the risk of pancreatitis, and those include pancreatic stents, non-steroidal anti-inflammatory medications, IV hydration, and other pharmacotherapy. It's not possible at all to cover all the different studies that are going on, but I just want to highlight the amount of work that's already been done to try to address this question, which was nicely summarized in this systemic review and network meta-analysis, looking at randomized trials comparing either one type of intervention to another or to a placebo arm. And the net sum of this was sort of summarized in this paper that involves 17,000 patients. And what was found, interestingly, is that no single intervention necessarily is superior than the other, but maybe we're moving towards a combination therapy that may be better than individual therapy. So IV fluids with non-steroidal anti-inflammatories given rectally may be a better approach than, say, rectal indomethacin or other anti-inflammatories alone. So this kind of moves the needle away, perhaps, from single intervention for pancreatitis prophylaxis to a more multifaceted approach. To that end, I will just sort of go back to this whole issue of single approach, which is the huge NIH-funded study that's been ongoing for several years, the SVI trial, which we will hear about in the next presentation, so I won't be talking about that. But I would like to highlight an important study in my mind that I came across, which is being conducted out of Italy, which is looking at the role of IV hydration and rectal indomethacin. This is similar to the fluid trial that was conducted out by the Dutch pancreatitis group. However, the fluid protocol in the treatment arm is a bit more aggressive than that, and this is for all comers. I think another important aspect of ERCP-related trials is that the risk of pancreatitis evolves during the procedure. What we may consider is low risk initially can turn into a higher situation, and so excluding patients, including patients with pancreatic cancer, can sometimes lead us down a pathway of not recognizing what problems are occurring. So I think this study will be an interesting one to see how the outcomes of therapy occur. Now, one of the main challenges with these studies is that what we use for diagnosing complications or adverse outcomes is the Cotton consensus criteria, which in itself is a tool that was constructed many years ago, looks at outcomes after 24 hours and may be due to patients may have symptoms that may not necessarily be due to pancreatitis, but may be labeled as pancreatitis. And we need to have better criteria. To this end, moving forward, a better tool may be using patient outcome measures, patient-reported outcome measures, which is something that was discussed earlier. Now, PanPromise is a tool that was developed in the setting of acute pancreatitis, not in the setting of procedures, but for all comers, which is a simple 7-symptom-based tool with a score of 0 to 70 that has been validated for acute pancreatitis. This tool, our group as well as at Penn, we looked at this as a marker for measuring symptom outcomes for patients when they undergo ERCP. So 679 patients underwent ERCP and were basically in the study included using PanPromise scores at baseline, days 2 to 3, 7, and 30. And after analysis of 150 patients, we determined that a score of greater than 7 at 7 days was predictive of having a prolonged high level of a PanPromise score. And when we tried to compare the PanPromise score to the Cotton consensus criteria, two things came up. One is, by consensus criteria, our pancreatitis rate was 4.7%, whereas with EPROM, it was 21%. And secondly, that there was no concordance between the two scores. In addition, the EPROM was associated with increased risk of hospitalization and worse quality of cost of hospitalization and worse quality of life scores. So as we move forward with these trials in the field of post-ERCP pancreatitis, we need to think beyond Cotton consensus criteria and actually look towards other patient-reported outcomes. In the interest of time, I'll skip to that over that slide. I do want to acknowledge that there is work being done in the field of pediatric pancreatitis, post-ERCP pancreatitis, and interestingly, the data seems to be more in favor of IV, smaller studies, but some data to support the use of IV nonsteroidals, and there is a study that's being started at Cincinnati Children's. I quickly want to just acknowledge the work that's already been done for endotherapy for necrotizing pancreatitis. These are 3 major trials that were conducted, and now the needle seems to be shifting towards optimizing the role of endoscopic therapies. There are challenges in this field. These came up in the previous session too, but heterogeneity in presentation, different strategies, time to resolution, and mortality still is not necessarily being affected by these various interventions. Also, there is a bias towards intervention when all patients are being treated by interventional endoscopists, or the majority are. That said, there are 2 important trials I want to bring to everybody's attention, which are randomized trials to look at the timing of endoscopic necrosectomy, early versus late, one in the US and one being conducted abroad. And the other one, I want to 2 more minutes and I'll be done. 1 more minute. To look at the role of endotherapy using a new device called the EndoRotor, which is a excavating device that is being done by the Dutch pancreatitis group. I'm going to skip over chronic pancreatitis because I think more important to and more relevant may be pancreatic cysts, and I want to bring 2 things to everybody's attention here. One is the evolving role of EUS as a diagnostic tool to now use molecular testing as a potentially primary role for stratifying cysts. I know there are other modalities such as more forceps and confocal, but I think this is the future where we have a wider gene panel to be able to assess the cysts. And now it's been also in a publication that is due to come out soon, being shown to be superior to current guidelines. And secondly, I want to bring to everybody's attention the CHARM trial. The first trial was for cyst ablation, which has been extended now to a larger study to look at the role of EUS-guided cyst ablation using gemcitabine and paclitaxel. And I think the outcomes of this will be important in this huge area of uncertainty in terms of managing patients with pancreatic cysts. The last time I was stared at this way, Dr. Pendall, was by my dad, when I was a teenager. So I really will wrap it up. So in conclusion, the landscape of endoscopic trial continues to evolve. Post-ERC pancreatitis continues to be an important focus of these trials, and there are multiple modalities, but we need to start thinking beyond single intervention and look at multiple interventions. And we need to have better tools for diagnosing these. I think the role of EUS will continue to evolve both in terms of diagnosis and management, especially when it comes to pancreatic cyst. And the role of endoscopic therapy for necrotizing pancreatitis and other modalities will continue to evolve. I appreciate your attention. Thank you.
Thank you, Mustafa. We're going to hold all questions to the panel at the end. And actually, thanks for sitting here with us. That's great. So next we have George Papachristou, and he's from Ohio State University Medical Center. And George is very active in clinical trials, including endoscopic trials, but also others as well. So welcome. And you're going to tell us what SVI stands for first.
Correct. Good morning, everyone, and thank you very much for the opportunity to represent a fantastic consortium, the SVI trial. SVI stands for stents versus indomethacin. This is ongoing collaboration for the last 7 years between NIDK and 19 currently sites in the US. Just to give you a background, a very important landmark, I would say, paper 10 years ago now from Joel Munzer, who is actually the PI of SVI, showed that the use of indomethacin in high-risk patients undergoing ERCP is effective and safe in reducing the risk of post-ERCP pancreatitis, with a number of patients needed to treat in that study of 13%. And then there were numerous, as Mustafa also pointed out, meta-analysis and systemic reviews. And overall, the conclusion is that non-steroidals are very effective in preventing post-ERCP pancreatitis with a 40 to 60% reduction rate. However, it's not all about non-steroidals, correct? Many studies in the last 2 decades have shown that pancreatic duct stenting can also be an efficient means of prophylaxis. And as you can see here, several randomized controlled trials and meta-analysis, and the number needed to treat is around 8, meaning for every 8 patients that replace a stent, a pancreatic duct stent, will prevent 1 event of post-ERCP pancreatitis. However, pancreatic duct stents come up with disadvantages. Number 1, when you attempt to place a stent but you are unsuccessful, this can be risky. Number 2, there are non-pancreatitis related stent complications such as PD strictures in around 5% of the patients. And number 3, and very important, you need to follow up with an abdominal X-ray. And in around 5 to 10% of the patients, you might need to perform a repeat EGD to remove the retained stent. And that is exactly the rationale, the conception behind the SVI study. Given the disadvantages of stent placement, can rectal indomethacin replace pancreatic duct stents in clinical practice? So this is a study that potentially can change the way that we manage post-ERCP pancreatitis prophylaxis. And there is some evidence in post-hoc, though, analysis that indeed non-steroidals, and especially indomethacin, might be more beneficial than pancreatic stent placement. However, we do need a study well-designed and big enough to give a definite answer to these questions. And that's exactly what SVI is. SVI is a multi-center, randomized, double-blind, so both the treating physician and the patients are blinded for 48 hours, non-inferiority trial assessing comparative effectiveness of rectal indomethacin alone versus a combination of rectal indomethacin and prophylactic pancreatic duct stenting for the prevention of post-surgery pancreatitis. Remember, in high-risk patients. This is not a study for all comers, but patients that are at high risk for post-surgery pancreatitis. Very briefly, the inclusion criteria from the study are any patient undergoing ERCP in whom pancreatic stent placement is planned for the sole purpose of post-surgery pancreatitis prevention, and patient and or procedure related factors conferring high risk. As far as our study plan, the consent is made before the ERCP in the endo unit. All potential subjects are consented so as to maximize enrollment. ERCP is performed per standard clinical care at the discretion of the attending endoscopist, and trainees are involved in this study. Actually, we're studying, it's a sub-study where we're studying how trainees are doing during SVI. The randomization happens within the room during the procedure. When one inclusion criterion is met, there are no exclusion criteria, and the papilla is visualized and accessible to the endoscopist. It's a web-based randomization system, which is accessed by the study coordinator in the ERCP room. The study plan of SVI, the randomization is a 1-to-1 randomization. Both arms are getting prophylactic indomethacin, and one arm gets on top of the indomethacin pancreatic duct stent, whereas the other does not. The stent type and technique are at the discretion of the endoscopist. When a PD stent is placed to facilitate access, and then the patient is randomized to no stent, then the stent can be removed at the end of the procedure. As we said, all subjects receive indomethacin at a dose of 100 milligrams per rectum once immediately after randomization. And there's a very tight window of 12 minutes. And very importantly, biospecimens are collected before, during, and after the procedure. So we're building a very robust biorepository as well. As far as IV fluids administration, because this is another important aspect of potentially prophylaxis. These are at the discretion of the endoscopist prior to randomization. After randomization, the care is dictated by either pre-randomization order sets. So what I personally do is I assign an order set before I even start the procedure with the aggressive fluid resuscitation, or by a blinded physician. Again, all the data about IV fluids are prospectively collected for analysis. Again, I think the beauty, but also the difficulty of this study is the maintenance of the blinding. All endoscopists and ERCP tech and nurses that are in the room during the procedure cannot be involved in the clinical care of the subjects for the next 48 hours after the ERCP. Again, as we said, we're using a provider-specific post-ERCP order set that is signed before the beginning of the procedure, and then there is also a blinded clinician who makes the decision for the first 48 hours. The endoscopy report does not state whether pancreatic stent was placed or not, and there's not a picture of the papilla from the end of the procedure. The endoscopist, of course, can talk to his or her patient and discuss the ERCP result, but cannot mention the study group assignment to the patient for the first 48 hours. So again, very robust, very intense approach to maintain the blind, which is critical for this study. As far as follow-up, there is a phone call by the research coordinator at each site at 5 days after ERCPs and 30 days after ERCP. What is the primary outcome of the study? And I think that's the big difference of this study in comparison with others, it's post-RCP pancreatitis defined per consensus guidelines. So we have to have new or increased upper abdominal pain and a lipase level more than 3 times the upper limit of normal within 24 hours from the procedure, and hospitalization or prolongation of existing hospitalization for at least 2 days. So a patient that gets a procedure and is kept overnight does not, and go home the next morning, does not qualify for post-RCP pancreatitis. Even more importantly, there is an outcome adjudication. So there's an independent panel of 3 ERCP experts, and 2 of the 3 must agree to adjudicate one event as post-RCP pancreatitis, using, of course, the consensus definition, but also very carefully reviewing all the medical records for patients that are admitted within 48 hours from the ERCP. So as you can see, the blinding and the outcome adjudication are very intense in this study. This is the study network, again, led by MUSC and Joel Muser. Ohio State is also part of the study and one of the highest enrolling sites. Historically, we have been 20 sites. Currently, we are 19, still enrolling. And this is just a snapshot of where we are with enrollment. And as you can see, MUSC, Colorado, Florida Hospital are a few of the hospitals that are top enrolling over the years. And this is a very important slide, gives you an idea what is exactly the cohort that has been up to now included in the study. And as you can see, around 26% of the patients have either clinical suspicion or known sphincter of Oddi dysfunction, which is fantastic. As you might remember, the critique of the New England Journal of Medicine publication back in 2012 was that most of the patients were sphincter of Oddi dysfunction patients, and this does not represent, clinical practice throughout the country. And even more importantly, 83% of the patients are enrolled because of difficult cannulation. So clearly, this is a study that does resembles the practice around the country. You have a patient in a remote hospital. A doctor is doing an ERCP or she's doing an ERCP. They cannot cannulate. It's a difficult cannulation. Does this patient need a PD stent or not? That will be the answer of this study. And difficult cannulation is defined as at least 6 minutes of time where the endoscopy is working to cannulate, and at least 6 attempts where you actually have clear contact for at least a second with the papilla. So very well-defined criteria. Moving along, I think we're very proud about the biorepository, because I think this is something that we really want to share with you, with all the great scientists in the room. As you can see, we have any sample collected in almost 900 patients, and serum collected both before and after the procedure in almost 400 patients. On top of serum, we have plasma, urine, saliva for DNA, duodenal fluid collected during the procedure in almost 800 patients. So it's a fantastic biorepository. Where do we stand with SVI these days? We're almost there. Our targeted sample size is 2,180. So as you can see, a massive amount of patients. The enrollment started 7 years ago in 2015 with 9 sites. I was privileged back then to be the site PI for Pittsburgh when we started. As you can see, we have almost 7,000 patients. Many of them do not reach the enrollment criteria in the room. And currently, we have almost 1,900 enrolled. We are at 87% of the target enrollment, and the projected completion is October of 2023. Again, I really want to thank Joel Muser as the PI of this study, Valerie Dukarski and her team that have done a fantastic job as a data management center. Of course, NIDDK that has supported this study through the years, and all the great site COIs, and I really am very honored and privileged to be part of this fantastic consortium. Thank you.
Thank you, Greg. Yes. So Have a seat at the table, George. Thank you very much. So the next speaker is Anna Phillips from the University of Pittsburgh. She's also interested in pancreatic biliary disease and measurements of outcome. And she has a title of her talk that she's going to explain to start with as well.
Thank
Thanks,
you so
Anna.
much for the introduction, Dr. Pandal, and thank you to the APA for the opportunity to present at this meeting. I'd like to thank the organizers and the leadership. This morning, I'm going to be talking about pancreatic quantitative sensory testing, specifically to predict treatment response for pain in chronic pancreatitis. And so we're switching gears a little here. I have no conflicts of interest to declare, but by way of background, first, again, we're talking about chronic pancreatitis and painful disease here. Pain in chronic pancreatitis is the most disabling symptom of the disease, affecting up to 90% of patients over the course of their disease. Now, there are multiple mechanisms that contribute to this, including inflammation, fibrosis, ductal obstruction, and neuropathy, among others. Invasive therapy is offered to patients whose pain is thought to be due specifically to pancreatic duct obstructive disease, where there may be stones or strictures in the pancreatic duct. However, as many of us have experienced, pain response to invasive treatment, even if successful, is unpredictable. This incomplete pain response to local CP therapies is thought at least to be partially due to central sensitization, a phenomenon of neuropathic and neuroplastic changes that result in symptoms and manifestations like allodynia or hyperalgesia. At present, though, and to date, there has been no clinical test available to identify central sensitization. So this schematic shows the concept of the nociceptive continuum in painful chronic pancreatitis, where all patients with painful disease reside somewhere on this spectrum. Some patients, approximately half in our cross-sectional data, reside on the left side of the schematic, where they process pain normally. On the far right extreme of this continuum are patients with central sensitization, those who have experienced pain for years and have undergone those neuropathic and neuroplastic changes that result again in things like allodynia and hyperalgesia. What we have done actually is created pancreatic quantitative sensory testing, which is a standardized set of bedside neural tests, which can serve as a proxy test for central sensitization. We use 3 different tools, including a pinprick stimulator in order to assess for phenomena of temporal summation, pressure algometer to look for pressure pain detection thresholds, and an ice water bath to evaluate a conditioned pain modulation paradigm. The underlying hypothesis of this work is that the presence of supraspinal central sensitization, as indicated by widespread hyperalgesia PQST phenotype, renders patients less likely to respond to invasive local therapies that are indicated for the treatment of pain in chronic pancreatitis. Now, this clinical trial, the overall aim is to test the predictive capability of this technique of pre-treatment PQST phenotype for pain improvement following invasive treatment for painful chronic pancreatitis. This is an NIH-NIDDK sponsored R01 funded multi-center clinical trial, and at present is taking place at 2 sites, the University of Pittsburgh, where I serve as principal investigator, and at Johns Hopkins University, where my colleague, Dr. Vikesh Singh, serves as the site PI. The plan is for enrollment of 150 patients total, evenly divided between the 2 sites. And at time of enrollment, patients undergo PQST testing and a set of questionnaires looking at patient-reported outcomes. A clinically indicated invasive intervention, either endotherapy or a drainage surgical procedure, as indicated for pain, is then performed for each of the enrolled patients. And patients are then followed up at 3, 6, and 12 months after that intervention. The primary outcome of the study is the association of pain change from baseline with PQST phenotype. This is measured by a single question numeric rating scale, range 0 to 10. This pain score is administered to the patients asking about their average pain over the preceding 7 days. This is measured at 6 months after intervention and compared to their baseline of the same measurement. Patients to enroll in this study have to be at least 18 years of age and have definitive evidence of chronic pancreatitis on cross-sectional imaging. They have abdominal pain, at least a 3 out of 10 on that numeric rating scale. They must be undergoing invasive therapy with either endoscopic therapy or drainage surgery procedure for pain management. Patients are excluded if they've previously had endoscopic therapy within the past 12 months, prior pancreatic surgery, if they are undergoing resective surgery such as a Whipple or pancreatectomy, if they have chronic pain of other etiology, difficult to discern, peripheral sensory deficits, or known pregnancy. This PQST testing algorithm is based on a nomogram in a previously published manuscript, but divides the patients into 3 separate phenotypes. On the left is that phenotype of widespread hyperalgesia. In the middle is segmental hyperalgesia. And then on the right is no hyperalgesia. Now, this trial only started just over a year ago, actually in July of 2021. And so far, I think we've made good progress. Our single IRB has been approved at the University of Pittsburgh, and our reliance agreement is already in place. We've completed our coordinating hiring, and we have finalized all of the case report forms, and our data management system is developed, and our data management group is actively maintaining that database. Our first patient was successfully enrolled on January 12th of this year. So far, we have enrolled 14 patients total, and this is just some baseline clinical characteristics of the group that we have enrolled. Mean age of these patients so far is 50.6 years. 79% of them are male. Now, the baseline median pain score of this group is 6.5 on that 10-point range scale. Etiology of chronic pancreatitis in this population, the majority so far have had alcohol etiology. The next most common has been idiopathic. The most common PQST phenotype in the group enrolled so far is segmental hyperalgesia, but approximately 1/3 have widespread hyperalgesia, which is consistent, again, with our cross-sectional data. Interventions that these patients have undergone so far include ERCP with S-wall, 9, ERCP without S-wall, 5, and then 1 patient has undergone a Pew-Stowe procedure subsequent to endotherapy that was unsuccessful. The next steps in this work actually are to optimize our recruitment and sample collection with an eye to completion of the primary endpoint for these patients at 6 months. We plan to perform a primary analysis upon completion of recruitment, which will be at least 120 patients with a 6-month follow-up. Analysis of our secondary endpoints will be following completion of 12-month follow-up for those same patients. And eventually, we will hope to disseminate the use of PQST testing to the clinical setting for optimization of patient selection for the invasive treatment of painful chronic pancreatitis. And so with my remaining seconds, I wanted to take this opportunity to thank my amazing group of contributors and collaborators, Dr. Singh and Dr. Fahi from Johns Hopkins University, and Ida, who's part of their team, Dr. Yadav, who's been a wonderful mentor and collaborator, Dr. Salomon, Althaus, and Vinos, as well as Tina and Matt from our center, Dr. Drews and Dr. Olison, who are credited with all of the theory behind PQST, Dr. Easler and Ashley from the Indiana University, who we hope will be contributing to this in the future, all the members of the International PQST Consortium, and the NIDDK and the American Pancreatic Association for their support. Thank you.
Thank you so much, Anna. Please also have a seat at the table. Our next speaker is Dr. Aliyah Uch. She's from University of Iowa and is interested in pediatric gastroenterology and pancreatology, and she leads in the CPD-PC consortium, the pediatric cohort with Mark Lowe, who's also here. Aliyah, good to have you.
Thank you, Steve. Thank you, APA, for inviting me to give this talk. It's wonderful to be here among you and meeting in person. So here's my talk. I have no relevant disclosures. So I would just like to emphasize that we face similar difficulties as our adult colleagues. So we have heard a lot about difficulties that we all face in the adult world. I will also would like to emphasize that the studies that paved the way to the clinical trials that I will try to emphasize within the next few minutes have been published within the last 5 to 7 years. And even the pediatric definitions of acute, recurrent, and chronic pancreatitis are only 10 years old. But so I'll try to emphasize and do my best to just tell you where we are with the clinical trials in the pediatric pancreatology. So as I prepared this talk, I used a few resources, and one, of course, was clinicaltrials.gov. And I tried to be as broad as possible. So I put pediatrics and pancreas, and I pulled about 61 trials. But I wanted to be active trials, so I just went to the next, and so that eliminated several. So I went down to 13. I actually looked really closely to all of them, but I will just summarize for you what those 13 trials were. So most of them were on either diabetes or a couple of them on tumors. Many of them were on cystic fibrosis unrelated to pancreas or pancreas, but pancreatic enzyme trials. So I ended up with 2 trials, active clinical trials on pediatric pancreatitis. So I'll just summarize them to you here briefly. So one was on pediatric acute pancreatitis, and that's patients trial. It's a single center pilot randomized control trial from Boston Children's Hospital. So the PI is Emmett Grover. This is funded by National Pancreas Foundation. It's really a pilot trial for a larger trial. So what he was trying to do is, can we compare what is being done at his hospital, which is starting with the opioids as the first line for treating acute pancreatitis, to perhaps just starting with something with a non-opioid. If the patients fail that, if the patients require an opioid, that is allowed. Either the family will require this, or the physician will give the order. The inclusion criteria is any patient less than 21 years old or over 8 kilograms. The patients already treated with the opioid, already very sick, are excluded. So this trial is enrolling. The second one is something that I've been involved in through the INSPIRE consortium. That consortium has been going on for about 10 years. So this is a natural history trial through the CPDPC consortium, NIH, NIDDK, NCI supported. So what we wanted to do is to see if the patients with acute, recurrent, or chronic pancreatitis, recurrent attacks of pancreatitis, or chronic pain would respond to a web-based cognitive behavioral therapy, which was studied by Tanya Palermo. And we partnered with her, and Dr. Lowe also was one of the PIs. So our inclusion criteria are here. So those are mainly adolescents. So far, we enrolled about 75 patients and their parents. The study is very well received once we really find the patient group that really fit into this criteria. So we enroll, and then we assess at baseline and 2 months and 6 months. What we're really looking for is the pain and quality of life in those patients. So, I found about 2 patients. I hopefully didn't miss anybody or any other trials through the clinicaltrials.gov. So my next strategy was just like, call a friend or ask a friend or other colleagues. So I asked a few friends, and through that, I found a few more things. So I asked my son, Abu Al-Heja, and then she gave me a few slides. So her study with Peter Farrell was on acute pancreatitis, and see whether lactated ringer or normal saline would be helpful in patients with acute pancreatitis. So those are all children with acute pancreatitis. So they randomized to receive lactated ringer or normal saline. And then here, just quickly going through these, they look at the inflammatory markers. Their primary outcome was CRP, and they look at the patient severity. The CRP was not very high at the on admission at 24 to 48 hours. Unfortunately, hasn't changed. Each arm has 38 patients. I think they had to finish the study a little bit earlier than they wished because of the COVID. Again, no difference in the length of stay, but the rate of discharge faster in the LR group, as she shared those slides with me. And she shared also this study that was recently funded by the NIH as an R01 study. This is to see if the MRI endoscopic MRI function testing would replace the EPFT, and the aims are summarized here. So the patients are going to receive endoscopic function test along with the MR, and then they will put through the automated process line to see if this could be a way to develop the normals and then perhaps predict the chronic pancreatitis in children. I also talked to my Hungarian colleagues, so I reached out to Peter Hegyi and Andrea Parniski, and they have, of course, apple and pineapple studies. Those are natural history studies. There are no intervention trials that I could report, but I was happy to see that their trial here on effort trial is including some of the pediatric patients. So they go down to 14 years of age, and this is to see if the dietary fat will have an effect on recurrent attacks of pancreatitis. So they will enroll about 384 patients. They just started enrolling. I don't believe there are any pediatric patients on this yet, but at least they're planning on it. So the patients have to have at least 2 attacks of acute pancreatitis within 2 years. And the last one has to be idiopathic. If they are already on a diet, on steroids, uncontrolled diabetes, or terminal cancer, malnutrition, etc., they can't be enrolled, but they will see if this will have an impact on quality of life or pain or recurrent attacks. So the study just started just about a month or 2 ago, and it will go for about 4 years. And really excited that this will involve pediatrics. And the arms are randomized, including either the standard fat, which is about 30%, or low fat, it's about 15%. So a lot of things, irons in the fire, but not a lot to report. So then the question is, so why is that? I mean, why can't we have more active clinical trials in pediatrics? One is the sample size and power. Those are rare disorders. I think in general, pediatric disorders are rare, but pediatric pancreatology is definitely one of the rare disorders. There are which require multi-center trials, and they are difficult to do. There are not many multi-center trials in the NIH, and definitely industry is not interested in this outside oncology. There are not many trials that involve pediatrics. And there's also a bias that is present about kids as being participants, which is not really the case. And then we again come to endpoints and outcomes, which is something that we're working on. The funding or the lack of funding is something to think about. The NIH budget overall for pediatric research is about 10%, even though youth represent about 22% of the US population, but they don't vote. And a lot of the chronic diseases start in the pediatric age group and even before birth, including obesity, mental health, and the cardiovascular. And I'm going to add the pancreatic diseases to that. The CPDPC consortium that the INSPIRE 2 cohort is in is very interested in ancillary studies and the clinical trials, and this is something that we're working on. So just to summarize, there are only very few pediatric active clinical trials. There are many reasons for that. The challenges are sample size. It's really, really hard to hit the sample sizes with the pediatric age group that we have, endpoints and outcomes, incomplete understanding of the natural history, funding, and we definitely need the support for advocacy and funding. So I think I'm done.
Thank you. Thank you, Aaliyah. We actually have a spot for you. We just made right here. Okay.
All right. Thanks, Steve, for taking care of the first 4 speakers. I'm going to introduce the next speaker, Dr. Elaine O'Reilly from MSKCC. Dr. O'Reilly is a leading expert in this field, and he has so many titles and has received so many prestigious awards. Just give you a few examples. She's the Rockefeller Endowed Chair in Medical Oncology at MSKCC, and she is the section head for HPV and endocrine chairs cancer, and she is also the PI for the MSKCC pancreatic cancer spore. So, well accomplished investigator. Elaine, good to have you here.
Good afternoon, or maybe almost good afternoon, but thank you very much for the invitation. Really a pleasure to be here. So the topic is targeted therapies in pancreas cancer. I just do need to acknowledge a number of grant and research funding supports and some disclosures, some of which do relate to what I'm going to talk about, and that there will be a number of investigational and off-label uses. So breaking it down into three topics, going to look at KRAS mutated and wild-type disease to start. And just a quick reminder here on the biology of pancreas cancer, that this is a RAS-driven tumor in 88 to 90% of people, primarily KRAS G12D in about a third, followed by V and R as the alleles that are dominant in this disease, and that's distinct in compared to colorectal and other malignancies where RAS mutations occur early and are critical to oncogenesis and maintenance and sustenance of this disease. When we look at RAS mutated pancreas cancer compared to wild type pancreas cancer, there's both a predictive effect, but a prognostic effect in that wild type disease does appear to do better. Now the data is a bit conflicting, and this analysis here from the CBio portal is has some limitations, but I think the theme is there. So we have proof of principle that RAS is therapeutically targetable in pancreas cancer, and this comes in the last 2 years with the advent of amazing kind of chemistry and drug development and other sciences coming to bear with the G12C story. This is a small subset of people with pancreas cancer, about 1%. And proof of principle with sotorasib, which is now FDA approved in non-small cell lung cancer. And just to emphasize the point here, this was a heavily pretreated population. And in that setting with a targeted agent to see more than 6 months of disease control for some patients is notable. And this was replicated with adagrasib, maybe some slight differences in terms of drug chemistry, and equally as potent in this setting. However, with all of these targeted agents, resistance is a key issue, and that's going to limit the impact of targeted single approaches in this disease, and the field is moving to combinations. So what about the more common allele variants in pancreas cancer? Some of the preclinical data targeting 12D is really, really exciting. And in fact, some of the data for pancreas compared to colorectal and other RAS-driven malignancies looks better. And this is one drug that's sort of proximate to the clinic, where in a relevant set of KRAS-driven models of pancreas cancer, there was a high response rate. And where these first drugs and related drugs have now been dosed. And not to get too into the weeds here, but the two kind of big strategies are, should you be targeting a single allele, or is it better in pan-RAS or all-RAS inhibition? And there's pros and cons in terms of addressing resistance pathways, in terms of specificity and off-target effects, depending on which approach you look at. But I think stay tuned in terms of this area. There's a lot of drugs in development. And we've also kind of proof of principle from other approaches, and this got a lot of publicity in early June in terms of looking at KRAS targeting using autologous infusion with specificity for 12D and TCR specificity in pancreas cancer, suggesting that again, in selected people, there may be value. Another big approach in pancreas cancer that's gaining some traction is this concept of minimal residual disease. After people have undergone surgery, diseases received adjuvant therapy, are there any additional things we can do to impact outcomes? And there are a number of RAS-targeted approaches being looked at in this setting. This is an example of one that we're collaborating on, currently looking at a 2-peptide KRAS vaccine, but soon to come covering the 7 most common allele variants in pancreas cancer. And it's a typical approach, enrichment based on RAS, immunization, observation, and then boost period and follow-up. And we'll look forward to seeing some data fairly soon on this. So what about KRAS wild-type pancreas cancer? Just the clinical context of this is a little bit common in younger patients, and as you can imagine, there may be a slightly different biology here. We also, in younger patients, see more germline alterations, but in this analysis from our group, about 16% of people under 50 had a KRAS wild-type tumor. And this can be subsetted out with several different groups, those who have MAP kinase pathway alterations, including the occasional BRAF V600E mutation, those that may have a little bit more enrichment for mismatch repair deficiency, and then these rare fusions that we see in pancreas cancer. And this is an example of one. It was mentioned earlier, NRG1 fusions, maybe 0.3 to 0.5% of people occur in younger patients. And in this setting, we can see significant effect in terms of radiologic disease regression, once more with a single targeted agent with a low toxicity impact. And at ASCO this year, we saw the first randomized study of 90+ patients with KRAS wild-type pancreas cancer receiving a monoclonal antibody against EGFR selected for less diarrhea and less rash. And in this study, there was a positive outcome, again, suggesting that this is therapeutically meaningful, even for a broader subgroup of patients. What we don't know yet is what the key alterations that underpin this wild-type subgroup from this study. So more to come on that. And for those that might be interested in reading more, I'll just draw your attention to a nice article in CCR led by Philip and colleagues, sort of summarizing an algorithm for how to approach pancreas cancer from the targeted perspective. Couple of slides on DNA damage repair. Platinum is a key targeted drug and maybe the most active targeted drug that we have in the setting of BRCA, PALB2, and homologous repair deficient states, where we see significant and sometimes very durable responses. The POLO trial was mentioned a little bit earlier. This looked at a PARP inhibitor in the setting of maintenance, so cytoreduced pancreas cancer in the metastatic space, platinum-sensitive disease, where progression-free survival advantage was identified, although no overall survival advantage. That led to olaparib being FDA approved in 2019, and rucaparib, trial led by Kim Rees-Binder and colleagues, getting NCCN guideline endorsement more recently. So we have two PARP inhibitors to utilize. So building on this, the question is the role for PARP inhibition with immunotherapy in other HRD or mutated HRD settings? And there are a number of genes that may fall into that category. And then we know there's this group that are platinum sensitive, but don't have any genomic underpinning that may benefit from a targeted quote unquote strategy. And that concept is being evaluated. A plug for the Apollo trial. This is being looked at in terms of PARP inhibition in resected pancreas cancer for patients who have a germline BRCA1, BRCA2, or PALB2 or somatic alteration. And this trial is actively accruing. So just a couple of other things, and not to take away in any way from Dr. Zaidi's presentation, but just to outline some really interesting science led by Dr. Vinod Balachandran from our group, who looked at short versus long-term survivors for patients who'd undergone surgical resection of pancreas cancer, and noted a couple of things, that there were pre-existing T-cell clones that were expanded in patients who were long-term survivors. And this led to this small study that was presented at ASCO this year, looking at a customized neoantigen vaccination mRNA-based platform using two different techniques of neoantigen selection to develop an individualized vaccine for patients with resected pancreas cancer. The study was designed to look at safety, feasibility, and could you do this in a time frame that was clinically meaningful, and to look at immune-based endpoints in terms of ELISpot and T-cell expansion. it met those two criteria. And when we looked at immune responders versus not, there was clearly a difference in outcome. So this is going to go on to be developed in terms of a randomized phase 2. So last couple of slides here, just to highlight a couple of other areas in terms of therapeutic targeting in pancreas cancer, looking at Claudin 18, building on our colleagues in the gastric cancer world. This is in late stage development in pancreas cancer, adding a monoclonal antibody to chemotherapy, an ongoing randomized study. And Dr. Simeoni mentioned this. This is, I think, also a very interesting area in pancreas cancer subtype, and the possibility that we may be able to select patients that could de novo be predicted to benefit from one of the two major regimens of gemcitabine and nab-paclitaxel or FOLFIRINOX. So very nice work coming from the COMPASS study, and now being further developed as part of this PASS-01 trial, which involves this immense translational effort that's so critical. And we heard all about this in the session this morning. And if there's one thing to emphasize, while we mightn't always win in terms of the therapeutics, there is so much to learn here. And these types of studies, which involve a massive collaboration, are integral to that effort. And I think also encompassed in this is a molecular tumor board where basic scientists, oncologists, surgeons, radiation oncologists, everybody's at the table sort of discussing all of the biomarkers and the organoid data, the genomic data, the RNA-seq data that can potentially provide possible therapeutic opportunities. So I'll sum up here, and this is a slide of borrowed and adapted just in terms of where we are in 2022 with regard to the actionable genome in pancreas cancer. Homologous repair deficiency, we have proof of principle with platinum and PARP inhibitors. A question beyond core BRCA1, BRCA2, and PALB2, what other genes are therapeutically relevant? And that remains to be seen. Mismatch repair deficiency in a % of people. KRAS mutated disease with regard to 12C validated, although no approved drugs yet. And arguably, pancreas cancer may become one of the most actionable diseases when we address the more common KRAS mutated setting. And I think there's a lot of excitement, as we said, in that space. And then in the KRAS wild type setting, that's where we see these rare but actionable fusions for which there are drugs available. So thank you very much. I should stop there, and I appreciate the extra minutes. Thank you.
All right, thank you so much, Dr. Riley. You can see here, we'll do one more chair. Yeah, thank you. It was an outstanding talk. So the next talk is pre-recorded. The speaker is Dr. Neha Zaidi from Johns Hopkins University. She's a physician scientist and a medical oncologist. Her research is focusing on developing novel personalized immunotherapy approaches for the treatment and prevention of pancreatic cancer. Please the pre-recorded talk.
Thank you so much to the organizers for the opportunity to present. Today, I'll be talking about immune-based therapies in pancreas cancer and provide you an update on immunotherapy pancreas cancer clinical trials. As you all know, the majority of pancreas cancers are insensitive to immune checkpoint blockade. Only about 1% to 2% of pancreas cancers are MSI high, but the majority are microsatellite stable, have low tumor mutational burden, and few mutation-derived neoantigens that are really critical for anti-tumor immunity. Furthermore, there really has been no response as monotherapy or dual therapy immune checkpoint blockade. That being said, special consideration should be given to pancreas cancer tumors with DNA damage repair deficiency, such as BRCA, that may be more susceptible to immunotherapy agents. The PDAC tumor environment, as you all know, is an immunologically cold tumor, unlike melanoma, which has a spontaneous infiltration of effector T cells. Pancreas cancer tends to not have as many effector T cells within the tumor microenvironment. Not only this, but there are other immunosuppressive cells that really need to be modulated in order to sensitize these tumors to immunotherapy. This includes the myeloid cells, and there are a number of agents here as examples that are currently being targeted to modulate this compartment. the stromal compartment that prevents T cell infiltration. And again, there's just a sampling of agents that are being used to modulate cancer-associated fibroblasts. And of course, there's a lot of interest in modulating the T cell compartment using strategies such as vaccines, adaptive T cell therapies, both T cell antagonist antibodies, as well as agonists. And I'll talk about that a little bit later. Given all of this, we believe that we really need a multi-pronged approach to heat up pancreatic cancer tumors. And one potentially successful strategy is to first use T cell inducing or priming agents to induce and prime high quality T cells into the pancreas cancer tumor environment. And examples of such agents include vaccines, oncolytic viruses, and adaptive T cell therapies. And then the second step is to use checkpoint tumor microenvironment modulators to optimize and maintain activated effector T cell function. There's been a lot of interest in using neoantigen targeted vaccines to induce high quality T cells. And these neoantigens can either be private or individualized to each patient, such that each patient gets their own personalized vaccine, or an off-the-shelf vaccine can be generated targeting public neoantigens such as mutated KRAS, which is ideal in the case of pancreas cancer, as it is expressed in over 95% of pancreas cancers. And these are just examples of clinical trials that are currently testing vaccines, most of the time in combination with immune checkpoints. And these are targeting either personalized neoepitopes or mutated KRAS neoantigens. Some key points to consider here is, are these strategies going to be more effective in early stage versus minimally residual disease where there's less immunosuppression versus more advanced disease? And the second consideration is that we really need to find the optimal combination of these vaccines with other immune checkpoint modulators. One study that's gotten a lot of attention recently, and I'd like to highlight, and this was data that was presented by Dr. Balachandran at the ASCO annual meeting, is a neoantigen targeted mRNA vaccine plus anti-PD-1 in resectable pancreas cancer. And essentially what they found here was that those patients who were able to generate a T cell response to one of the vaccinated neoantigens had a greater recurrence-free survival, as you can see here. We are also testing a mutated KRAS long peptide vaccine in combination with Ipi and Nivo for patients with resected pancreas cancer. And here we've generated a vaccine that's targeting the 6 most common KRAS mutations in pancreas cancer. We've completed enrollment into this cohort, and we are seeing the generation of robust de novo mutant KRAS specific T cell responses in the peripheral blood post-vaccine. Not only vaccines, but also genetically modified T cells have gotten a lot of interest, specifically in targeting mutated KRAS. And this here is a case report of a patient, a metastatic pancreas cancer patient who received autologous T cells engineered to express 2 KRAS G12D reactive TCRs. And this patient really had a very impressive response in the lung. And this is very exciting. But some key considerations here is that this is specific to certain HLAs, so not yet broadly applicable. And the second key point is that these responses for this case study and similar ones have largely been seen in the lung as opposed to the liver, where the tumor microenvironment may be very different. That being said, there really is a potential for off-the-shelf therapies here, specifically targeting RAS, where we could generate a library of reactive TCRs that covers the breadth of KRAS mutation and HLA alleles. In terms of other TME immune remodeling agents, you may ask, is more always better? And here I'd like to highlight the PRINCE trial, which tested a CD40 agonist, anti-PD-1, and chemo. CD40 has really gotten a lot of interest in that this antibody can activate dendritic cells, increase T cell priming, and increase tumoricidal macrophages. And these combining CD40 with chemo and PD-1 has shown early safety as well as clinical activity in a phase 1 study, which eventually led to a phase 2 study with these 3 arms, either Nivo plus chemo, CD40 plus chemo, or the triple combination. And you can see here that the triple combination did not do any better than the doublets. But what's important to highlight here is that the study was able to identify a number of key circulating and tumor biomarkers. And this will really help drive future investigation, and that these studies may need to be more biomarker driven. Similarly, neoadjuvant immunotherapy trials have really provided mechanistic insights for future trials. And here I'd like to highlight a study that was just published in Cancer Cell in just last week, where the study employed multi-omics analysis comparing pre and post-treatment specimens across 2 arms. Arm A was GVAX, which is a whole cell vaccine, versus GVAX plus nivolumab. And essentially what the study found was that those patients who did worse had a higher density of tumor-associated neutrophils, which are immunosuppressive, and those patients who did better had a greater number of CD137 positive T cells. And so based on these studies, and this is part of a platform trial, there's now 2 other neoadjuvant immunotherapy studies, one testing GVAX plus a CD137 agonist plus PD-1. This study has enrolled, but has reported some pathologic complete responses, and also a second arm, which is GVAX plus anti-IL-8, and this trial is currently enrolling. Lastly, I'd like to end by saying, although most pancreas cancers don't respond to checkpoint blockade alone and really need priming agents, special consideration should be given for those pancreas cancers that are have DNA damage repair deficiency. And there have been studies that show that pancreas cancers with biallelic loss of BRCA1 and BRCA2 have a slightly higher tumor mutational burden as opposed to wild type tumors. And in a small retrospective study showed that there was a response to Ipi/Nivo in the subset of pancreas cancer tumors. And lastly, there was also another study that showed a greater response in a niraparib plus ipilimumab arm versus niraparib plus nivolumab in the maintenance setting after platinum-based chemotherapy. Based on this initial data, there are a number of studies that are testing PARP inhibitors plus immune checkpoint blockade. So in conclusion, the majority of pancreas cancers do not respond to single or doublet agent immune checkpoint inhibitors alone. Pancreas cancers will require T cell priming and inducing agents in combination with immune tumor microenvironment modulation. Neoadjuvant and adjuvant trials are revealing important mechanistic insights, which will allow for scientifically driven clinical trials. Spatial and multi-omic analyses of trial specimens will also allow for future development of biomarkers that will help guide immunotherapy treatment. Homologous recombination deficient pancreas cancers deserve special attention. Current and future IO plus PARP inhibitor studies will address the role of combination strategies for this subset of pancreas cancers. Thank you very much.
All right, thank you very much. Now question and answer time. Myself.
The microphone, yes. Myself Abuel Haja, Cincinnati Children's. Thank you for a great session. I took some notes, but I really want to make a comment that I made in Pittsburgh at Pancreas Fest, so the people who were there would remember it. It's and we had a great NIH pre-meeting at Pancreas Fest designed for clinical trials. So the comment is really more of a reminder on the challenges of clinical trials when it comes to inclusion of children and how they design. Really, we're dealing with low numbers with the disease, especially with pancreatitis. So you would need multi-center with very special pediatric expertise. They are a vulnerable population, so definitely I don't advise adults to work on studies on research on children alone. They really need their pediatric experts to help lead and guide the regulatory aspects. Inspire has done it very well, and that's why it has many, many centers compared to the adults, because we cannot achieve the same goal without uniting a larger number. But I do have a suggestion, and that is the catch. So let's tinker the system and maybe start thinking a little different. And that would satisfy how the NIH now really calls for inclusion across the lifespan for all studies, and a justification of why you do not have children as part of your studies. The excuse should no longer be, we're only an adult institution, we don't care for children. We could really partner and reach out. A great example would be a disease that affects the life spectrum, like drug-induced pancreatitis. There's a great work going on.
Sorry, Sam, can you keep the question short?
Yeah, no. I will just, I'm done almost. I would say that you will find it very easy. So this is an example where peds and adults work together to set the platform. The pediatricians are organized, passionate, they're fun to work with. And I really want to give a plug to the Hungarian group for starting such an effort. Thank you.
Anyone comment, respond?
I think it's important to include children in studies as much as possible, so I agree. But I mean, how do you organize that effort is very hard, as I, emphasized in my talk.
Dr. Pando, you have some questions?
So I have two questions, but I'll start with one and maybe later, if we have time, I'll ask the second one. So this one, I can reach out to Eileen first. And that is, how are we thinking about the tumor fibroblasts these days and their contribution to the growth of the cancer cells and the immune microenvironment? I think we talked less about that.
Yes, so thank you. That's a great question. Where are we with regard to stromal targeting in pancreas cancer? And have we seen successes? So I think there's a lot of really interesting science, and many in the room have contributed to that. And certainly our understanding of that has vastly changed. That hasn't, I would say, as yet translated into therapeutically effective approaches. And there's, I think, still a lot of hope, though, that as we better manipulate and modulate the tumor microenvironment, maybe we'll have some successes. And, we've had a couple of examples of very nice translational studies that haven't borne out. So, yeah, I think stay tuned on this in this area, too.
Thank you, Eileen. More questions, Steve?
Yes, I just had a question for the invasive ERCP and sphincterotomy trials. Speakers, those patients that might be pre-trial on statin drugs or valproic acid, do you exclude them from your trial studies? Since that might, especially if they admit to alcohol consumption and in particular binge drinking.
Can someone repeat the question?
The question, I believe, is how do we consider statins and valproic acid in clinical intervention trials for pancreatitis? Okay,
Yes,
George, you're on.
Perfect. Thank
Yeah.
you.
As far as SVI, that was not an exclusion criterion for different reasons. Number one is that it's just a small portion of patients that might be on these medications. Number two, it's a pretty big size trial. So we were more focusing on being inclusive rather than exclusive of patients. And our exclusion criteria had more to do with the indication and the technique rather than, medications or other, social history. We did record alcohol consumption and smoking in our forms, but we did not exclude those patients.
So here.
Yeah, thank you for this session. The question I had was related to post-ERCP pancreatitis trials. And what really piqued my interest was, Mustafa, you mentioned the pan-promised results, which is that the pan-promise related metrics were fulfilled in about 20% of all comers with post-ERCP pancreatitis, if I heard that correctly, compared to only 4% of the Cotton criteria. I guess the questions are, of course, is it relevant or not? But it's such an important question because many of the preclinical studies, I'm thinking of my own interests in calcineurin inhibitors, such as tacrolimus, show a 50% reduction in preclinical models. But then when you go into the clinical scenario and you're dealing with 4% to 2%, the numbers needed are so high. And so I guess my question is, would you consider PAN-PROMIS as a primary endpoint over the Cotton criteria moving forward?
Thanks, Sohail. I think it's a consideration to be now moving potentially away from Cotton criteria. This may sound controversial, and actually moving towards symptom-related outcome measures, because as we do these procedures, we have patients who do well from a technical standpoint and procedurally everything goes well, but they have pain. And that may not be pancreatitis pain. They have pain regardless, or they may have nausea, vomiting. There may be multiple reasons. And I think we are hung up on a criteria that was developed that has so many limitations with respect to objectivity, as well as patient-related symptoms, that I think there has to be a better way of measuring it. But if you look at all the trials in the past and the ones moving forward currently, we're just continuously using this method because that's what we have. So this was I'd give credit to Nikhil especially for coming up with this idea of applying symptom-related outcomes. And I think the next step in our minds is how do we potentially apply this to future clinical trials. So I agree with you that that's the way we need to take this in.
One more question.
Hi, thanks for the session. I had a question about the role of KRAS immunotherapy. So given that KRAS is also, I think, considered to be one of the earliest mutations in the development of pancreatic cancer, is there any thought or ideas about maybe using these KRAS targeted vaccines in people with early stage high risk lesions rather than full-blown PDAC?
Perhaps I can start. Yeah, I think there's a lot of interest, and actually I'll defer this to Dr. Zaidi, who's on the video here, who has a very interesting trial in this space, in the pre-invasive space. Maybe, if you would like to add on that.
Yeah, so thank you for that question, and sorry I didn't get to cover that. So we do have a clinical trial based on some preclinical testing our KRAS vaccine in patients who are at high risk. So these are germline carriers. Predominantly, it's a small pilot study of 20 patients. We've vaccinated now 5 patients. But yeah, there is a great deal of interest in targeting RAS early when there's kind of less immunosuppression and less immune tolerance.
Does the vaccine have like a side effect profile at all? Does it cause pancreatitis, for example, or anything that would make it like unreasonable for people who don't have full-blown cancer?
Not that we've seen. We've have quite a bit of safety data now from the resected pancreas cohort, as well as some of these high-risk patients, and we haven't seen anything more than kind of local reactions and no pancreatitis so far.
All right, we have time for one more question.
I got my one more question. So this is in response to what Masan brought up and also directed to Aliyah. So my understanding from your literature is the majority of your patients have mutations as cause of pancreatitis in children, at least chronic pancreatitis. And these are in the CFTR range, a majority. And so I'm just wondering, in spirit of collaboration, like Masan pointed out, are there any barriers to trying CFTR drugs that are used in cystic fibrosis?
So I think so. I mean, currently, the CFTR modulators are really indicated for patients with cystic fibrosis and pancreatitis. So, I mean, a lot of the patients that we have, I mean, if we identify that they have cystic fibrosis and they are pancreatic sufficient and they continue to have pancreatitis, I mean, definitely that is indicated. But if they have no CF causing mutations, and we have a significant amount of those patients in the INSPIRE cohort, about 30% of them have CFTR mutations that are not CF causing. Currently, I mean, the FDA indication is not for those kind of patients, but I think it's very important that we do the sweat chloride on those patients. And this is something that as INSPIRE, we encourage that this to be done. And if the sweat chloride is elevated, but not in the CF range, I think you can make the case, at least at your institution, for those patients to receive the Trikafta, which is the combination therapy. But it is not, you have to jump through the hoops. So I think, probably at least at a consortium level, this is something that could be tried. And Maisam is nodding her head.
Very
so.
short, very short.
What's wrong, man? Can I talk?
Yeah, you can talk,
So
but
it
keep it
will
short.
take 30 seconds. There's an active P30 NIH-funded study housed at Cincinnati Children's exactly examining that, but it's not a trial yet. And what happens is that in the lab, we have the rare or the unknown function of those different CFTR mutations that we get back on pancreatitis and different GI disorder patients get tested in vitro by growing the intestinal organoid, nasal organoids, and pancreas on a chip, led by Dr. A.P. Naran now at Cedars. And that is exactly the premise, that you test the drugs and CFTR correctors and modulators in vitro. We actually have taken the information back to the clinic on some patients, and we got the drug approved. That's it, 30 seconds.
Thank you. Thank you, Maisam, for keeping short. I think they will conclude right on time. I want to thank all the speakers for the outstanding talk and the question and answer section. This is wonderful. And I also want to thank my co-chair, Dr. Steve Panels. And you have some housekeeping announcement.
So thank you, Min, and thank you, everyone, as Min said. But also, we want to let you know that you could go to lunch.
Please come back before 1:30. 1:30 will start. Thank you.